project manager from Rate Reform, and I use she, her pronouns. And our goal today is to present to you our methodology and rates for dental. We want to do some introductions on our side before we get going. David?
Hi, good afternoon, everybody. My name is David Jorgensen. I think most of you probably already know me. I'm the Director of Data Analytics and Rate Setting for MaineCare. Thank you for spending time with us on this dreary Friday. I will go around to the team of presenters today. The team that has worked on this dental reform is a little bit broader than that, but we're going to limit introductions to speakers today. Phil and Kathy, if you could introduce yourselves.
Yeah, good afternoon. My name is Philip Dubois, Senior Data Analyst with MaineCare. And I worked on the benchmarking analysis to update the dental rates.
Good afternoon, everyone. My name is Kathy Coolidge, and I am the policy writer for this dental policy for MaineCare.
Thanks, Kathy. And Mandy, since you're facilitating the screen sharing today, if you could give a quick introduction as well, that'd be great.
Sure, thank you. Amanda Lee, Rate Setting Coordinator at MaineCare.
Thanks, Mandy. And we're also joined by our Medical Director, Courtney Platson. Courtney, I think, will maybe give a fuller intro later in the day, but thank you for joining our forum, Courtney.
Thanks. Happy to be here with everyone.
Thank you, Courtney. First slide, Mandy. While Mandy's pulling up the slide, I want to remind everyone that we are recording this presentation today, and the recording and our PowerPoint presentation will be available at our Rate Reform website. And when Mandy will send out that notice with links, so you will be able to access that information. Our agenda today, we did introductions. We're going to go through the rate reform process, benchmarking and rate setting, moving to a rate determination. There'll be a time for comments and questions and next steps. Before I get through the rate reform process, I just want to mention that we've set aside time for questions at the end. We are using a Q&A function today. You will be able to enter questions during the presentation into that Q&A function that you'll find at the bottom of the screen. And when we get to the question portion of this presentation, we will read those at that time and provide instructions on how to raise your hand so we can call on you. So an overview of the rate reform process. We have rate reform law known as the Maine Law for Title 22 MRS subscript 3173-J, which establishes the process for principles for the rate determination and includes sets a schedule for regular rate review and adjustments, ensures the review of relevant state and national data to inform rate amounts and payment models, formalizes a clear and transparent process for rate determinations. Some of those steps include public initiation notice, stakeholder engagement, data collection, public presentation of draft rates, an opportunity to provide an official written comments. The department then reviews the comments and responds. And then it also establishes the MaineCare Advisory Committee with a schedule to update the determination process. And then also the Technical Advisory Panel, which meets and convenes more than twice a year if the commissioner deems so, advises on related technical matters that are appropriate, and reviews our annual rate determination schedule. Next slide. So as we were talking about how this pertains to the dental process specifically, in the past, we have had a public forum with this group on November 29th. And then today we're talking about draft rates and benchmarking. We will have, after this presentation, an official comment period that will be 2 weeks for you to provide your comments, official comments into my email. Then we will review those comments and work on written responses that will get posted to the website. And these rates that we're going to present today, the target effective date is 7/1/24. And at the bottom of this slide is just kind of a visual of some of the steps that I talked about on the previous slide. And below that, if you get, is also our link to our website. Thank you, Mandy. Next slide. As we move into the benchmarking and rate setting portion of the presentation, I'm going to hand this over to Phil.
Great, thank you, Jessica. And let's go ahead and advance. So for the benchmarking, we determined a commercial median benchmark for each CDT code. The commercial payer data for dates of service from July 1, 2022 through June 30, 2023 was sourced from the Maine Health Data Organization's All Payer Claims database. The commercial allowed amount for each claim is equal to the sum of the paid amount, the copay amount, coinsurance amount, and deductible amount. For determining the commercial median benchmark for each CDT code, data was limited to commercial payer data, dental claims paid as primary, and claims with a rate paid greater than 0. And then the median allowed amount across the valid paid claims for each code was established as the commercial median benchmark. And MaineCare claims were not included in our analysis. We also determined an all states Medicaid average benchmark for each CDT code. The rate for each service was sourced directly from each state's Medicaid agency website. For each service, a benchmark rate was established as the average of all states' rates. Some states established a rate differential for child and adult services. So in these instances, the child and adult rates were averaged, and then the resulting average rate was used in determining the overall average of all states' rates for a service. So on the next slide, we will look at the resulting benchmarks for one code as an example. So we're looking at D0120 periodic oral eval. As a point of reference, the current MaineCare rate for this service is $34.70. The commercial median allowed amount is $48, so that is our commercial benchmark. And then the all states Medicaid average rate is $29.01. So that is our Medicaid benchmark. Over the course of the next few slides, we'll look at how we turn these benchmarks into rates. So the standard rate setting method considers the two sets of benchmarks derived from commercial and state Medicaid program reimbursement rates in order to determine the MaineCare rate of reimbursement for each CDT code. The standard rate setting method first considered the commercial payer benchmark. The MaineCare reimbursement rate is set using the commercial benchmark if the benchmark is determined to be reliable. The commercial benchmark for a particular CDT code might be flagged as questionable if no commercial benchmark is available, or if the CDT code has low commercial utilization. So for CDT codes where the commercial benchmark was deemed to be unreliable, the rate setting method then considered if an all states Medicaid average benchmark was available. If there was no Medicaid average benchmark for the code, then the code was flagged as a potential exception, and then an options analysis was conducted to determine if using the commercial benchmark would result in an appropriate rate, or if another methodology would need to be developed. Let's go ahead and advance to the next slide. So the rates for dental services are established for each CDT code based on the type of service. Diagnostic, endodontic, periodontic, and preventive services are prioritized, and rates are determined using either 67% of the commercial benchmark as the standard option, or 133% of the all states Medicaid average benchmark when the commercial benchmark is determined to be unreliable. The rates for the remaining service types are established using either 50% of the commercial benchmark as a standard option or 100% of the all states Medicaid average benchmark when the commercial benchmark is determined to be unreliable. So on the next slide, we'll look at the resulting rate for D0120 as an example for how we apply this methodology. So again, you'll recall that the current main care rate for D0120 is $34.70. The commercial benchmark of $48 passed our reliability checks. So then we apply the 67% of benchmark, and then we also apply an inflation factor to the rate. The inflation factor is based on the consumer price index for dental services. So then the resulting new rate for D0120 would be $33.54 under this methodology. And I'll now go ahead and hand it over to David to talk about the overall impact on reimbursement and our recommendation.
Phil. I'll just before I jump into that impact, just say that this whole process that Phil has described is the methodology that's described in our Section 25 rule day, and so benchmarking update process was the scope of the effort to update rates for July of this year. If you advance to the next slide, in the next slide, one other provision that was in the current rule was that there are two codes that have temporary exceptions to have some higher rates, and those exceptions were also slated to expire at the end of this fiscal year. So those rates would have also decreased on 7/1 under the existing rule. Unfortunately, what we found through this analysis was that our existing methodology would result in some significant rate reductions across the board in Section 25, largely with respect to the commercial benchmarks just not increasing at the same pace as inflation. So the COLA that we provided last summer means that our existing rates have grown a bit faster than what the commercial rates have grown. And there may be other reasons why the commercial benchmarks just didn't increase by as much as the COLA that we gave, but that's really driving the fact that this benchmark analysis would result in lower rates than the current rates. So when we looked at this analysis and given current utilization estimates, this would, following the current methodology, would result in over a $2 million reduction in investment in dental services. So that is not great. This wasn't what we necessarily expected to happen, and it's not what we want to implement. So the team has done a lot of work exploring different options, what we have the authority to do, and what we can do at this point. So the recommendation that we've landed on, if you can go to the next slide, is that we'll keep rates exactly as is. We will extend those temporary exceptions for SDF and extractions so that there won't be, so that those temporary higher rates will not expire. Those will continue as is. And then the rates that are set off the benchmarks, we don't think that that's the most appropriate methodology anymore at this point. We recognize that rate reductions at this point would be not great for our dental provider network and our members who need access to these services. So we're going to be moving quickly to do what we need to do to get the authority to not implement these rate decreases and just keep the current fee schedule constant for now. So normally at this point, we would be presenting some draft rates to you. Since our recommendation for these draft rates is to keep our rates the same as what they are currently, we can share the link to the current fee schedule, but those are the recommended rates that we will be moving towards implementing in July. So with that, I think the question on everybody's mind will be, okay, so what next? If you don't think that this is the right methodology anymore, what are we going to do now? Where do we go from here? So if you can move on, under our normal rate reform timeline, every section of policy is slated to have their full rate determination every 5 years on a 5-year cycle. What we're proposing is to take dental off of that timeline to see when we can jump into another full rate determination for Section 25, recognizing that the methodology that we had landed on 2 years ago no longer seems to be the most appropriate methodology when we're doing these updates on a every 2-year basis. We don't really want the unpredictability of maybe sometimes it'll go up, maybe sometimes it'll go down. So we would like to do a full rate determination to identify a more robust and reliable methodology that that we think is maybe more appropriate than what we had originally landed on. We don't have an exact timeline for when we'll be able to do that yet. There are a lot of priorities that we're juggling with other services, other sections of the policy that are also already on our rate determination schedule. So we need a little bit of time to assess and prioritize and make sure that we're not delaying other work that is also high priority work, but we want to commit to doing this rate determination at the very least ahead of that 5-year timetable, and we'll hopefully be turning around the results of our assessment of that timeline fairly quickly. Also, I want to take a second to note that while this rate determination process is a very more formal process that's really focused on the rates and the rate system, there has been a lot of requests from providers to engage in a broader way. So I wanted to invite Courtney to chime in at this point and talk about potentially some broader opportunities for engagement.
Thanks so much, David. I just want to thank the whole team that has been working on this. I know this was a huge lift to do this work. I am the medical director and I started in the fall. So I've been here a relatively short time at MaineCare. And I just want to acknowledge during even starting the new oral health benefit till now, we have not had consistent medical director. And so the hope is moving forward that I'll be able to attend the MAC dental subcommittee and be able to help really represent our senior management team. And I just want to share, I have worked in federally qualified health centers for 12 years alongside my dental colleagues. And I personally, as a primary care provider, care so deeply about oral health and know that in order for my patients and for people to be their healthiest selves, oral health is essential. And so I feel so strongly about really moving forward in this work. And I was trying to reflect, MaineCare Medicaid has been around for almost 60 years, and we've only added the dental benefit in 2022. And so I really feel like this program is in its infancy. And the hope is that, this, like David said, this rate determination process is a very formal, specific process, and it's only one tiny component of the oral health program and in the way that MaineCare can support. And so I'm hoping moving forward that I'd love to hear in part of our conversation today, other ways that MaineCare can also support the oral health community. What are the ways other than in addition to the MAC Dental Subcommittee, what are the other avenues? How do we better coordinate with oral health through CDC? So across DHHS, I'd love to hear ideas on that as well. But I just wanted to come on here and just publicly share my commitment to supporting this work moving forward and trying to have consistent leadership and representation from SMT, and specifically around oral health moving forward. So I welcome thoughts and ideas, in our conversation today, but also moving forward. And I'll share my email in the chat for folks. Happy to set up individual meetings just to get to know people better, because I know that I've been attending the MAC, but I haven't been able to attend the dental subcommittee yet because I have clinic on Mondays. But I really look forward to that work and partnering with you all in these efforts moving forward. So I'll turn it back over to you, David.
Courtney, and just for clarity, when Courtney says SMT, that's the MaineCare
Yeah.
Senior Management Team. If we haven't used that acronym before, that's what Courtney was referring to. So at this point, we will move into the comment phase, comments and questions about this proposal, and I'll turn it over to Jess to facilitate that.
Thank you, David. We'd like to open up the invitation for you to raise your hand and let us know if you have a question or a comment you would like to make. I know Courtney said she was going to put her information in the chat. I will turn it back on before we end this presentation so she can do that. We did the Q&A section and we didn't want two avenues for people to send us messages. So if we can try to keep our questions to a shorter time frame. This is not the avenue for the official comment periods, but we do welcome your questions and comments about what we've presented today. I just want to go over really quick for those who haven't been to a presentation before, to raise your hand. If you're on the internet, you select the reactions or the participants meeting controls at the bottom of the screen, then raise your hand. I will select people in the order that they've raised their hand. You can also press Alt-Y on your computer keyboard to toggle to the raise your hand option on or off. If I have anybody on the phone, you would hit *9 on the keypad of your phone. I'm going to go ahead and go to the questions. I'm gonna have to select and ask you to unmute when I do that. So I think Kaylee is the first person.
Great, thank you. So my name is Dr. Kaylee Williams. I'm the clinical director at Waterville Community Dental Center. I'm also the president of the Maine Oral Health Centers Alliance, which represents 6 of the largest nonprofit dental centers in the state. I want to definitely thank the department for what has been done in the last few years to help support and raise up dental services. I know that there has been a big effort for this work. I'm, I guess, glad to see that we won't be losing any funds. That would be quite devastating. I want to just raise up the awareness that it's encouraging to hear that there will be more work done moving forward to try to improve this situation. But to Courtney's point, I think we will need to be really realistically discussing some ways that the department can be more directly involved in providing more direct support to providers on the ground Right now, there is almost no specialist provider network in the state of Maine for Maine Care patients. In Kennebec County, we have 0 oral surgeons who can accept our referrals, and we're having to make really tough decisions about potentially closing our doors to new patients because we cannot guarantee that we can provide them care. So while this is really important for us to be moving in the right direction overall with the benefit, I just want to make clear that our patients cannot wait another year or another 2 years for some sort of change to happen within the provider network. The existing network is so dramatically exhausted. Myself literally having a mental breakdown in front of my staff this week because of the inability to provide care to patients who were desperately in need and in pain. This is happening across the board. This is happening everywhere. Providers are incredibly concerned about their ability to maintain their staff and their workforce. The question that I have is, I don't know when that can be answered in this setting, but it is, I think, really important that what are the more immediate steps? What can be done by Maine Care leadership, including the ones that are here, but even escalating to the commissioner's office and to the governor's office to make them aware of the critical state of emergency that we are in the dental world right now. I'll pause there. I'll stop there. I don't have a lot more to add other than wanting to just raise those incredibly significant concerns that we have as a provider community.
I just wanted to start by, thank you so much for your leadership and the work that you're doing. And I feel like what you're describing is, partially moral injury when you see a problem and, dentists are doing this work because they want to help people. And when you are able to see an issue that someone can't access help for, like that is just straining you and your teams all across the state, and how devastating that can be, especially just knowing how important someone's oral health is if they need oral surgery. And so I just want to recognize like how difficult of a position that is to be in. And I certainly know it. When my patient, I work with a dentist, we're literally trying to call all over the entire state to try to find resources. And I think your point's a good one of like, how do we escalate that? How do we understand? How do we address this from not only within Maine Care, but across DHHS as a whole? So I don't have a good answer for an immediate next step, but I just want to say I hear you, and I recognize the difficulty that this puts you and your teams and all general dentists in. So thank you for sharing, and I'm sorry to hear you had such a hard week.
We'll just add that our senior management team will be meeting on this topic next week, and we will be discussing our roles and responsibilities and how we can best support those conversations and partnerships with you all.
Thank you, David and Courtney. Teresa, I'll give you permission to unmute. Thank you.
Hi, I'm Teresa Hill. I'm the executive director of the Maine Dental Association. The first thing I want to say is my computer is tapped right now. So if I just want to know, if I drop at any point, it's a technology error, not any offense that I'm putting towards Maine Care. First of all, I want to thank you, David. That must have been a very challenging and team, very challenging prep to share that information with the community, and starting off with rates that indicated a potential loss certainly set the stage for where we were headed. And so I also want to thank Maine Care for agreeing to continue to offer the rates at the same rate that they are offering. And I say that, and I kind of choke on it a little bit, because we are, Kaylee did a great job of expressing it, but I cannot underscore enough how much we are struggling to keep providers continuing to take Maine Care patients Businesses are losing money, so much so that they are considering taking out lines of credit in order to pay their staff. This has been, you add on to it the Change Healthcare issues that have been happening over the last couple of months, and you can imagine the stress in which people are working under. I do appreciate that, funding is an issue, but I have two requests, and one of them is I would like to ask MaineCare and the administration to consider more. I would like them to consider something that gets providers from dropping this coverage, quite frankly, because I was sitting here thinking about how I was going to message this to my membership. And I'm a pretty good spin on words, but there's no way that I can spin this. This sounds great. And so I have to tell you, I'm incredibly concerned. And so what would be really great and would leave people with a better taste in their mouths is if MaineCare and or the governor would consider something additional at this point. It isn't too late. The budget is still open. And so I guess that I would like that request. And the second request is, as you may know, the MDA has put together with the many people on this call a task force to discuss MaineCare. And we are looking for a huge piece of legislation to submit in January. I would ask anybody from the MaineCare office for their assistance and for their partnership on areas that hamstring you. What is preventing any changes from happening that might be legislative, that needs to be, that might be in statute or maybe even in rule, that we can help support changing. We try to be good partners. And so, I just feel like I need to just express again my appreciation for the difficult message that was just given, the manner in which it was given, and also my incredible concern about what this means for the very, very fragile MaineCare network that is current. Anything that you can provide would be great. I'd be happy to meet anybody at any time. But this is a huge disappointment, and I don't think any of us are hugely surprised, but at the same time, we kind of hold out hope that it might get better. So I will leave it at that. But again, just David and team, thank you very much for all of your hard work and being so thoughtful in your messaging.
Thanks, Therese. And I appreciate that the absence of very bad news is not really good news. If you have concrete suggestions on what that something more that you referred to would be, we'd love to hear them. And you can submit those in the comment process. You can copy myself as well when you send those to Jessica, and we'll do what we can to escalate those. I don't know if there are any opportunities to raise things with the legislature right now. They are scheduled to adjourn next week, so that those opportunities may have already passed. But I definitely appreciate any ideas you have on what that something more will be. I do also want to recognize the team's efforts. When we benchmark our rates to other external payer benchmarks, we can't always control what those external payers do. This year, Medicare also reduced their rates for a lot of physician fee schedule items, and we just had to follow those Medicare rate reductions. So in a lot of ways, our efforts to keep rates flat, it is something more that we have really tried to do for dental services that we were not able to do for those other physician fee schedule services. I know that doesn't, it's maybe not reassuring to you, but it was a lot of effort went into just keeping things the way they are. Leo, I see your hand is up next.
Yeah, thank you, David. And, you know, I would associate myself with Therese Cahill's comments and Dr. Williams' comments also. You know, there's no question that everyone on this call is trying to act as a team as best they can. There's a tremendous amount of empathy in this room. And that's always a really good thing. I would like to focus just on the methodology piece if I could. And I think my understanding is that because of the regulatory methodology that you have, that you were constricted to use that methodology. And as a result, that methodology caused a decrease in the rates especially because the commercial providers those rates were not increased to the level of inflation. Do I have that pretty much right, David?
That is correct. Yeah, we used the same methodology this year that we applied 2 years ago, but we did give an 8% cost of living adjustment last summer. So when we reapply that same methodology on the updated data, that increase that we provided last summer means that our fee schedule increased at a faster rate than what those benchmarks increased.
Okay, gotcha. So one of the things that I've wondered from the beginning, and I think I mentioned this at one point when you were at either a MAC meeting or another meeting, the methodology requires you to use the average when you are considering costs. And I asked at one time, and I'll ask again, what happens if you use the median? Now, assuming that the median is not something in the regulation at this point, have you run any trial calculations to see what happens when you use the average, the median instead of the average in your calculations?
Yeah, I think it might be instructive to go back to our slide that has the methodology for the different benchmarks. I believe it's slide 8. And we do have a somewhat different approach for the commercial benchmark and the Medicaid benchmark because we have the claims data on the commercial side. Those are commercial payers within the state of Maine. The All-State Medicaid benchmark is based off of fee schedules and not based off of claims. So the way those benchmarks are constructed are a little bit different. So we do use the median on the commercial side. So we look at all of the claims that for that service, and we select the median allowed amount for the commercial benchmark, and then on the Medicaid side, we use the average of the fee schedule amounts from those other state Medicaid agencies.
Right. So even if you use the median on the other state state average rates, you wouldn't, it wouldn't, it doesn't seem that that would be making a tremendous difference in the calculation. Because the average benchmark for other states, the beginning rate for the rates in other states is really low compared to where we come out, if I'm understanding that correctly. The average in other states is lower than what we're using now in this state.
Yeah, that's right. And so when we did use the commercial benchmark, we for those preventive type services, we actually paid above benchmark, used the 133% of benchmark, rather than just using that average, because we wanted to be better than average. Right. Yeah.
Yeah, but even so, right.
Right.
And,
So sorry to cut you off. I did just want to note, because we're talking about moving away from this methodology and looking at potentially new methodologies in our near-term future rate determination. Just wanted to call that out, and I'm certainly happy to answer other clarifying questions, but if I think we would love to kind of get into those details more in another future rate determination. But if you have other methodology questions, we can certainly answer those. But it just wanted to note that we are moving away from this methodology with our recommendation this year.
Yep, no, understood. And I appreciate the answering my question and explaining it so that even somebody who has very little to do with rate setting now better understands it. And appreciate your time. And again, it's just a demonstration of how much you care about being clear and transparent in what you're doing. But the bottom line here, I think that we all understand, is that there's an emergency situation that exists. There appears to be nothing that's going to happen with the rates that's going to improve that situation. And, you know, I'm not sure I understand at all what getting away from this methodology to something else means, but it's clearly not the time to go into that right now. But you know, I think I'm as everybody, I think, is a bit disappointed that we can't do something immediate to improve at least the amounts that people get paid. And yeah, it's great that you're not going to pay them less, but you know, there are providers that are not even subscribing to commercial insurers anymore. And even if you went to the highest commercial rate that was being paid in the state by the biggest carrier as a benchmark, that probably wouldn't help everybody anyway. I mean, that would be great, but it wouldn't encourage those people who are no longer taking private insurance to become a main care provider. Thank you.
Yeah, thank you, for those comments. And if you have other thoughts or ideas about what a different methodology would be, we also welcome that in the comments. But we'll definitely be engaging when we do start that future rate determination. Becca.
Hi, thanks. I'm Becca Matisovich with the Children's Oral Health Network of Maine, and I'll just say ditto to like all the thanks for the hard work and the transparency and everything. And I agree with everything that's been stated so far by other speakers, but I guess maybe I'll offer a little bit of a different angle. as well, which is that I'm not sure the rates are actually even relevant if you don't have a provider network. And in many of the categories that were listed on the slide, you don't have any providers. So like, I don't even know if it matters what the rates are, or you have only a couple, and they're not going to last long when there are only a couple. So, so I do want to make an immediate concrete recommendation, because as of the October data dashboard data, looking at the past year at that point, there were less than 80,000 MaineCare members who received any dental services at all in the past year. And 60,000 of those got their services from 3 types of providers: nonprofit dental centers, FQHC or health centers, and pediatric dentists. And in those 3 categories of providers, there are only 44 of them. There's 8 nonprofit dental centers, there's about 20 health centers in that category, and 16 pediatric dentists. So I would like to recommend that you convene them either as a whole group of 44 or in those 3 groups and ask them, like, what do they need to stay open? What do they need to keep serving as many MaineCare patients as possible safely and without the moral injury that we're hearing? Because we are all, as a state, relying on these 44 providers to carry an enormous load on behalf of the state, and it's crushing them. So I would ask you to pull them together and ask them what they need to breathe to be able to survive for however long it's going to take to build a MaineCare provider network that can actually serve the entire MaineCare membership, because it's going to take you a few years to redo the rates, and the rates are not the whole solution. And if you wait until the next rate reform to test whether the rates are enough of a solution, we're going to lose the entire network, and we may lose it anyway in the meantime if we don't do something more. And so, and then even if the rates are the solution, it's going to take years to rebuild the network to the point that it can serve everyone. So that's, no matter how you slice it, that's a long-term endeavor. But it's not that many providers that you could find out what they need and then act on what they tell you, whatever that takes. That would be my recommendation. And thank you for the opportunity to even offer it.
Thank you, Becca. I really appreciate that suggestion and that idea. And that feels something really tangible and something that we can act on. So I appreciate you sharing that.
Absolutely. And also thank you for pointing out that rates are maybe not the only solution that that might be needed to fix the access issues that our members might be experiencing. Lindsay.
Yes, hi. Sorry I don't have a video. Can you hear me though?
Yes, we can hear you.
Okay, sorry. I'm a MaineCare provider and I own a private practice. And I certainly would like to reiterate some of the comments today just about the frustration felt, because I think the lack of understanding by the general public of this situation, or not necessarily the general public, but the members themselves who have MaineCare don't quite understand MaineCare reimbursement or MaineCare policy. So then the ones that look like the bad person is the provider who's trying to give these services. Because I do wholeheartedly agree that the rates are not, they are 50% of the problem. The policy is 100% of the problem. As I primarily do dentures and extractions in our office, and extractions are very easily done. The provider can determine We don't need prior authorizations. Prior authorizations are for dentures to me at this point seem absolutely useless. They are on the portal, they say approved, we get, it's a waste of paper. It honestly is. I mean, they're approved in seconds. It's just time for my staff to have to go through the hoops to do it. And to be honest, even if we say on the paper that this patient doesn't fit all of the guidelines, that they've already had a denture made by somebody else in less than the 5-year limit, they're still approved. So I don't really understand the process at this point. So I think the policy should 100% be reformed, more so than the rates. And I think that as much as I would love to have the rates increased, I also feel like having the members contribute to their treatment would provide incentive for them to continue care. So I think the policy of not being able to, you can only take the main care fee, that's a policy that I would encourage you to change. When we're looking at, you guys are looking at these commercial insurances, well, you can get the commercial insurance money, but then you can charge them the remainder. And that's the biggest difference. You can't charge a main care patient any type of money. So the rates would be fine, and you would have more providers if a patient could take their main care insurance anywhere they wanted and use it as private insurance. And I know that's like far reaching and probably not even ever possible, but I feel very frustrated that, it's very frustrating that we have to go through so many things and then our payment reimbursement is so slow. I'm a private business and I have to pay my employees every week. And when we call in for help, nobody knows anything about rates. I will tell you that in the last year, I would say 70% of my main care patients that come in also have private insurance, and main care is a secondary. And that is the hardest thing in the world to navigate. And none of the provider specialists or even the people assigned to us know how to navigate it. So I can certainly appreciate the rates and the changes. But I certainly agree with Becca that you need to get these providers together in a room and you need to see what challenges there are, because the challenges that we're having are the reason that people won't take it. I guess that's all I have, but and I also cannot imagine lowering the extraction rate, because that's just going to overwhelm every emergency room that's already overwhelmed.
Thank you for your comments, and thank you for your work serving main care patients. I really appreciate it. I heard a couple comments, one regarding our streamlining our prior authorization process, another to do potentially some broader policy reforms, and a third would potentially be requiring or allowing cost sharing from the patient themselves. So I've captured those ideas and written those down. I think some of these will certainly address with the work Courtney and our senior management team will be diving into for the broader engagement strategies, and we may be able to address ideas around member cost sharing when we do another rate determination, but I've written that down here and captured that. I also welcome you to submit those comments in writing as well. Therese, I see you have your hand up again.
Yeah, I just quick comment. I really like Becca's idea of convening the providers. I would have one ask around that. And that is that if they need something you can't provide, that they know that. Be honest with them. Don't, I would just say that for me would be fabulous, customer service and, more genuine if, they ask for something that you know they can't get, or that is not that easy, and you were able to communicate with them immediately, so they don't leave that kind of meeting believing that it's actually a consideration. But I do love that idea, just as long as it's real, that's all. Thank you.
Thanks. Yeah, I appreciate we don't want to give anybody false hope that MaineCare will be able to provide those solutions if it might require another actor to do so. I don't know, Courtney, if you have anything else to add to that.
No, I think that's really helpful. And I think not everyone knows the federal requirements of Medicaid. And so I think, like you're saying, receiving and hearing some of the challenges and being able to pretty transparently say, these are the things that we can absolutely work on, and these we're not able to do because of Medicaid regulations, and how we can partner, or what are the other organizations that are better positioned to address those issues. So I agree that that's a great kind of tactic to take, and that we want to be transparent in what we are able to work on and what we are not. So thank you for that. Mike?
I'm sorry I missed a decent amount of this meeting, so I'm sure some things have already been addressed. I've spent the last 3 days treating close to 30 MaineCare patients under general anesthesia that require extensive treatment. I was just remarking to my office manager that this session of general anesthesia cases is the worst I've ever seen. I had multiple kids, and when I say multiple, I mean more than 10 kids who had every single tooth in their mouth decayed. It's a tremendous undertaking. We pay an anesthesiologist to come and provide these services. And as practice, we do this 3 days a week or 3 days at a time every other month. I work a day for free to pay that anesthesiologist what we lose in reimbursements from MaineCare on treating these patients. So I've been in the office since 7:30 this morning. One of our cases, we had to coordinate with an oral surgeon to have him come here and treat a patient that needed, very extensive work. Doing work for free. I'm losing money on these cases. So the short portions that I've heard of this meeting are incredibly frustrating, that to hear that we're not seeing any more money. I'm going to continue to lose more money and more ability to pay my staff to be here on a day that they usually wouldn't be working, to bring in other providers. As Becca mentioned earlier, the provider network is incredibly limited. And I literally just watched the beginning of this meeting before I had to go in and start another case and said, I don't know how much longer I can do this. And I look at situations like this, and if you lose me as a provider, there is essentially nowhere for kids that need general anesthesia cases to seek care in the state of Maine. We need to be doing way more than we're doing. Hearing that, in some cases, the recommendation would be for rates to go down. I'm glad that we're not going to decrease them, but it feels like another slap in the face at a time when the provider network is essentially nothing.
Yeah. Again, thank you. I really appreciate your work with MaineCare members, and I appreciate your comments. I definitely want to see those in writing, and if you're willing to submit those, that would be very welcome. having that documentation, even if we can't immediately act on it, is really important for us to be able to prioritize. And yeah, I don't know if I can respond any more than that at this point, but we will be looking forward to engaging with you more as soon as we can.
Mike, thank you for taking the time. Thanks for sharing. And it's really hard to hear. It's hard, and but it's so important to know. And I think we all, like, everyone is aware that things are at a breaking point, and to hear that you're having to not get paid to pay a general anesthesia to come, an anesthesiologist to come to provide those services is awful. And I'm so grateful that you're doing it. And yeah, I know that there's no words at the moment. I just want to express my gratitude for the work that you're doing.
One last call for comments. For everybody who has raised your questions and concerns, we really appreciate those. I know this was not welcome news, but we value your input and your feedback. And if you have any other comments, feel free to raise your hand. Definitely afterwards. Jessica's email box is open for the formal comment process related to the rate determination, but Courtney will be available as well. She has provided her link in the chat, and if you're not sure where your comments should go, if they're formal rate comments or broader engagement comments, you can send them to both Jessica and Courtney at the same time, and we can figure those things out on our end. I'm happy to be included on those emails as well if you're still not sure who should be receiving those. So I think seeing no other hands raised, I'll turn it over to Jess for next steps and the closeout of the forum.
Thank you, David. Next steps, before I go to that, I just wanted to point out that Courtney did put, like David said, her email in the chat that you can see. I also posted our rate reform website in the chat so that you can go there. You can probably be able to view this presentation and a recording before you receive the notice with the links. I've also provided my email. I feel like a lot of people probably already have it, but I wanted to give it to you again. I'm more than happy to take any emails through me if there's somebody else who you're trying to coordinate or give feedback, but I will be the one that you will submit all your official written comments to. The next steps in this process right now are the emergency rulemaking period. Comments due to my email by 2 weeks from now, 4/26/24. We will then review the comments and have responses to the comments. 7/1/24 for the rates. And we will be working towards a timeline that we can perform a rate determination. But as has been stated, we're very grateful for you working with us and all that you do for the MaineCare members. And Courtney has given her email for you to correspond, and David writing down everything that you guys have said. Hopefully we can continue to work together to bring some continued positive things. Thank you all for joining.
Thank you.
Thank you, everybody.